Okay, everybody, welcome to this ERKNet ERA EDTA, or I should actually say ERA webinar on cystinosis. My name is Tom Nijnhuis. I'm an adult nephrologist from Radboud University Medical Center in Nijmegen. I will be your moderator today. And before I introduce today's speaker, Aude Servais, I would first like to ask you to take notice of the question bar in the GoToWebinar panel. So if you at some time during the presentation want to ask a question or want to ask a question in the discussion afterwards, then please put the questions in the questions bar. Well, today I'm very happy to introduce Dr. Aude Servais. She's a senior nephrologist at the Department of Adult Nephrology at Necker Hospital in Paris. And as such, she's part of the Reference Center for Child and Adult Hereditary Renal Diseases and the Reference Center for Inherited Metabolic Disorders at Necker Hospital. She's also the Vice Chair of the Board of the ERA EDTA Working Group on Inherited Kidney Diseases and Chair of the ERKNet Working Group of Metabolic and Stone Disorders. And her research interests include genetics of FSGS and Alport syndrome, C3 glomerulonephritis, and the management of cystinosis in adolescents and in the adults. So in addition to that, Dr. Servais is also the principal investigator of the European Cystinosis cohort. So it goes without saying that she is the right person to inform us today about especially the adult nephrologist view on cystinosis. Again, I would like to urge you to put the questions in the question bar for the discussion afterwards. And Aude, the floor is yours.
Thank you very much for this nice introduction. We will talk today about cystinosis, but we will focus on the adult point of view. So I think that cystinosis provides a very good example of a very pediatric disease with now a spectrum extending into adult medicine. For instance, in the European radical cystinosis cohort, more than half of patients living with cystinosis are now adults. And so these patients are likely to be followed up in adult units, and the adult services should offer a model of care including both the kidney, but also all the extrarenal manifestations of the disease. And we will discuss about that today. Just a brief introduction on cystinosis, which is, as you know, autosomal recessive disease with an incidence of 1 on 100,000 to 1 on 200,000 births. And it is due to a mutation in the CTNS gene, which codes for cystinosin. Cystinosin is a cystine transporter, so there is a cystine transport defect, as you can see here, and an accumulation of cystine in the lysosomes, and finally some crystal formation. But the pathophysiology of the disease is much more complex, as you can see here, and I invite you to go to this very nice review to have all the data on that, because it's a little bit out of the focus today, but it's a much more complex disease than only a lysosomal crystal disease. From a genetic point of view, there are more 140 different mutations that have been described, but the more frequent is called the European deletion, which represents more than half of the patients with cystinosis. There are 3 different forms of cystinosis, but the more frequent is the infantile form. And in this form, you will have some severe mutation in both alleles. The clinical presentation of the patient is usually around 4 to 6 months of age with a failure to thrive, some rickets, and a Fanconi syndrome, which is a proximal tubule dysfunction, including hypokaliemia, low serum bicarbonate, hypophosphatemia, and normoglycemic glycosuria. There is also a polyuria, which can lead to dehydration. Initially, the renal function is normal, but if you perform a kidney biopsy, which is not mandatory at all, you would find some crystals like this, and then these crystals will activate inflammasome and lead to fibrosis and finally to renal failure. So my first question is, how can you confirm the diagnosis of cystinosis in a patient? It's your turn now. If you let me know when the answers are there, because I cannot see them.
Okay, I have the answers for you, Aude. About 65% think it's leukocyte cysteine dosage. A little bit less, 59% thinks it's actually genetic diagnosis. And then we have 30% for the ophthalmological exam, and then some people urine cysteine dosage and crystalluria. But let's say most people are divided between leukocyte cysteine dosage and the genetic exam.
Yeah, I should have told you that different answers were also right. Regarding the crystalluria and the urine cysteine dosage, it is not the cystinosis. This is for cystinuria. I just write it down because some people may don't make the distinction between the two diseases, but it's a completely different disease. And for the cystinosis, you should perform leukocyte cysteine dosage maybe first, because it's probably the easiest one, and also ophthalmological exam, and then I would suggest to perform some genetic exam too. The white blood cell cysteine dosage will be increased, and then you will have the diagnosis of cystinosis. Then you should also perform a slit lamp examination, which is quite pathognomonic, and you will observe some corneal crystals that you can see here. And these corneal crystals are always present after 18 months of age. Today, some ophthalmologists can perform some confocal microscopy, and here you can see all the different stages of crystal in the cornea of a patient with cystinosis. So it's very useful first for diagnosis, and then of course for follow-up. And today, if it's available, I would also perform a genetic study to confirm the diagnosis. Then first, the treatment will be symptomatic, including hydration, electrolytes, potassium, phosphate, bicarbonate, citrate, sodium, vitamin D. I will not go further into details because it's really the symptomatic treatment of Fanconi syndrome. But then my second question is there any specific treatment that we could add for the patient? It's your turn. So should we use dipenicillamine, cysteamine, or tiopronin?
I think the answers are still coming in. 94% go for cysteamine treatment, 6% for cysteamine treatment, and nobody for the dipenicillamine or the tiopronin. So, so the distinction between cystinuria and cystinosis is now clear.
Okay, thank you. So you are very good, of course. This is cysteamine. Cysteamine is a cysteamine bitartrate that is available today. Two different forms exist, maybe depending on the country you are living. First is cystagon, which is an immediate release cysteamine. And in this case, you have to give a dose every 6 hours, including night, for the patients. And then in some countries, Process B is now available, which is a microspheronized enteric-coated form, allowing twice daily dosing. And it has been shown that there is no inferiority between the two forms on the white blood cell cysteine levels. So the right dose should be around 1.3 grams per meter, and the maximum dose in adults would be 2 grams per day. or also you can adjust to body surface. And the objective of the treatment is to have a cystine level below 1, like a heterozygous porter of cystine. But this treatment has some side effects. First, some gastrointestinal complaints, and also a very disagreeable breath and sweet odor, which is due to the conversion of cysteamine to methanethyl and dimethyl sulfate. So it's quite difficult to tolerate the treatment. So it's a very important work for the nephrologist to help the patient to take the treatment. We will speak about that later. And there is also a topical treatment, ophthalmologic treatment by a gel formulations. In Europe now, I think that in most of the countries, it is Cysta drops, which is available, which is a gel formulation, but in the US, you will use Cystaran, and other cysteamine local treatment are available. With Cysta drops, which is a gel formulation, the patient can administer treatment only 3 to 4 times a day, which is better with very immediate release treatment. And this is very efficient to solve the crystals. So this is a typical case of a patient that an adult nephrologist may meet at a transition visit. This is a patient that I follow with the diagnosis of cystinosis at 13 months of age, including failure to thrive, polyuria, rickets, and she started the treatment around 15 months. She had the proximal tubulopathy, the corneal crystals, and she had a lot of problems to take the treatment during all her adolescence. And then at 18 years of age, I met her. She had a creatinine around 188 micromole per liter and a cystine level of 3. I told you that the goal is to have a cystine level below 1. So there's a lot of work, but this is really a typical patient. So what should we do? The first thing is to have a look at the complication of the disease. We already spoke a little bit of the kidney, and then most of the patients will reach end-stage renal disease. In this historical cohort, the age at end-stage renal disease was 11 years, and 90% of adult cystinosis patients had already reached end-stage renal disease. And then other complications may occur: hypothyroidism, diabetes, neuromuscular complications, stroke, and these complications may lead to dependence or death. So what should we do with this patient? The first thing is to have a look at the kidney. This patient have chronic renal failure, but has not yet reached end-stage renal disease. So first, it's quite good because she's arriving at adult age, like some patients today, without having already reached end-stage renal disease. In the French historical cohort, which included 86 patients, the mean age as end-stage renal disease was 11 years. But there was a very important difference between patients who had not been treated at all or who had been treated after 5 years of age compared to patients who were treated early. And we had a gain of around 4 years of life with a native kidney. And in this cohort, around 10% of the patients reach adulthood with a native kidney. And this number is increasing now. If we look at the European cohort recently published by Francesco Hema, it's very interesting to note that the prognosis of kidney function has really improved between the 70s to the 90s. And here we are then, the renal survival is much better than in the 70s. The median gain in renal survival is around 9 years. But finally, by multivariate analysis, once again, it is the age when cysteamine was started, which is associated with the delayed development of end-stage renal disease. So it is very important to start the treatment as soon as possible, as soon as the diagnosis is performed. But the treatment is difficult. It has some side effects. And for the other nephrologists, there is a lot of work. As you can see in this very nice study by Gemma Receptor, you can see that 94% of children always follow the prescription, maybe with the help of their parents, but in the adults, only half of them always follow the prescriptions, and in the adolescents and in the adults. And then many of them change the schedule, miss some dose, never follow the prescription. So this is a major point with this treatment. And there is an important impact on of compliance on end-stage renal disease. We try to select the patient according to 3 degrees of compliance. And as you can see here, the patient with a better compliance had a better renal survival than a patient with a poor compliance. And in the same way, it was shown by Dr. Nesterova that using a composite score of compliance for each year of very good cystine depletion, the patient will have 1 year of preserved renal function. And this is very important because there are not so many treatments in nephrology which are so effective. But then my patients reached end-stage renal disease, and we had to talk about renal transplantation. Of course, renal transplantation is a treatment of choice in these young patients. Both living donor kidney, including the parents, or cadaveric kidney perform very well. And it has been shown in the European patients that the results of kidney transplantation in cystinosis patients is better than the patients having a transplantation for another cause. And the 5-year graft survival was better in nephropathic cystinosis patients than in other patients. And we performed the same analysis with a long-term survival of a cohort of 30 patients followed in France. And we matched the patient with controls. First with controls matched for age and center and general aspects. And then also we excluded from the analysis the patient who had a disease which could recur, like HUS or FSGS. But there again, we found a better long-term graft survival in cystinosis patients than in controls. We don't know exactly why, but this is the positive point for the patients. The patient with cystinosis can experience some rejections, so they should be treated with immunosuppressive medication as all the other patients. Some of the treatments, steroids, tacrolimus, maybe it would increase the risk of developing diabetes, but we found finally that post-transplant diabetes was as frequent in cystinosis patients than in control patients. So we are not used to use some special regimen for these patients, but it can be discussed. Then now the patient is transplanted. We are very happy. Should we stop cysteamine? Let me know.
Okay, the poll is in progress. Not seeing any results yet. 90% of people say you should not stop cysteamine treatment, and 10% would stop.
In the past, in the very long term, in the very past, our colleagues stopped the treatment, but then they found all the extrarenal complications of the disease. So of course, we should not stop the treatment. We will have a look at the extrarenal manifestation of the disease and on the impact of the treatment, but I would also add that the treatment by cysteamine has also an impact on survival. So it is very important to motivate the patient not to stop cysteamine. I told you all the problem of medication adherence of the patients with cysteamine. So you will have a lot of work about that, but it's very important not to stop. Because first, the cystine may accumulate in the thyroid follicular cells, which would cause some fibrosis, atrophy, and dysfunction, as you can see here on this picture. And you will have to treat the patient with a thyroxine supplementation, which is not very difficult, but you have to look at the thyroid function in the patient in the long-term follow-up. And it had already been shown that the treatment by cysteamine, if it is started before 5 years of age, has a significant impact on the occurrence of hypothyroidism. But even if the treatment is started later, it still had an impact on the occurrence of hypothyroidism. So it's very important to continue the treatment for this complication. Then also you may observe some diabetes. So you have also to check for that in the follow-up of the patients. The cystine may accumulate in the beta cells of the islets of Langerhans with some crystals, like you can see here in this picture, in the pancreas, and then a complete disorganization of pancreas. And once again, the patients who are treated early, before 5 years of age or early, have a delayed occurrence of diabetes and less frequently some diabetes. But there is also a positive impact of the treatment if it started later. So it is very important also to have the treatment with cysteamine not to develop diabetes. Then a major problem for the adult patient when they become older is that cystine may have some deposition in the muscles. And you will maybe observe some progressive distal myopathy with weakness, which initially involves the distal extremities. So have a look at the ends of your patients. And then maybe the patient have some myopathy. But if we perform some imaging in some patient, here is a 37-year-old man, which is followed in our hospital, and we perform a whole body magnetic resonance imaging, and we found in this patient clinically some involvement of the axial, proximal, and distal muscles. But here on the MRI, you can observe that the muscles are atrophied and fatty replaced. So even in a patient which has not a lot of symptoms, you may detect some myopathy, which is a major problem. What about the treatment? Once again, if the cysteamine treatment has been started early, there is a significant delay in the occurrence of this kind of neuromuscular disorders. However, we don't know exactly yet if the patients has stopped the treatment and restart the treatment later, if the neuromuscular disorder will be treated or not. So once again, it's very important to have a very early treatment. Then the patient may also have some thoracic muscle weakness, which may result in a restrictive lung disease. And this pulmonary disease is correlated directly with the myopathy. And in this older study performed 20 years ago, you can see that the frequency of pulmonary dysfunction increased with the number of years without any treatment, and the frequency decreased with the number of years with oral cysteamine therapy. So there again, the cysteamine therapy is very important. And then this patient with a myopathy may develop some swallowing dysfunction, once again due to the deterioration of oropharyngeal muscles. And the adult patient with cystinosis may have some dysphagia, first for solid food. And as you can see in this recent study, using a score of swallowing function called Thomas score, the patient with cystinosis compared with patient with myopathy, border myopathy, had a similar dysfunction, but it was much worse than healthy adults. If you look at the bites, the masticatory cycles and swallows, it was much higher, so it was worse in cystinosis patients, even if they had not so many symptoms. And finally, aspiration is a potential very severe complications. And once again, this kind of complication is correlated with the presence of muscle atrophy, and it has been shown that the swallowing severity score is increasing with the number of years without histamine. So for that also, the long-term histamine treatment is very important. Then have a look at the neurocognitive function. It has been shown that the patient have a normal intelligence, but they may have some mild neurocognitive abnormalities. In particular, there is a specific improvement in the processing of visual information with a relative weakness in visual motor, visual spatial, and visual memory skills. So this may be associated with some academic difficulties, in particular in arithmetic. And then we had a look on the central nervous system complication of a cohort of 18 adult stenosis patients followed in our institution. And finally, we found that in this cohort, 39% of patients had at least one central nervous system complication, which included some cognitive defects, some memory defects, some seizures, and in one patient, a stroke. We performed the mini-mental state examination in half of these patients, and the median score was 27, with most of the patients having a very good score, but some patients having a very low score. The lowest was 20. So we performed in these patients some neuroimaging, and we found a very high prevalence of radiological defects. 40% of patients had this clinical complication, and 90% had a radiological abnormality. And in most of the cases, it was a cortical or central atrophy observed in 70% of patients. But it was not really correlated with the symptoms. And it has been shown in other studies that this atrophy is observed in cystinosis patients, which is quite strange for the young age. And by functional imaging, we found that there was a correlation between the leukocyte cystine level and the decreased rest cerebral blood flow, in particular in the frontal cortex. And when we looked at the complications and compared the patient with and without complications, we found that histamine treatment, once again, was very important. So it could be one of the determinants of this cognitive and neurological complications of the disease. Here is an example of a patient presented with isolated ventricular dilatation, and here patients with cortical atrophy, ventricular dilatation, and also some diffuse white matter anomalies. But these white matter anomalies are less specific. Then let's have a look at the fertility. We know that the men may have an hypergonadotropic hypogonadism, and it was recently published that all the men examined who were more than 20 years of age had this hypogonadism. But the patients followed today with optimal treatment had normal testicular volumes and testosterone levels. But if we go further in the analysis, the author found that 80% of the patients presented with azoospermia or oligospermia, even if the hormonal tests were normal. It had been published in the past that in one patient with a biopsy that there was a fibrosis, but there was no germinal dysplasia, and there was a sufficient spermatogenesis. And in this more recent study, you can see here, I don't know if you recognize that because we are not used to this kind of biopsy, but you can see here some lysosomes in the Leydig cells in the testicular interstitium. And it has been shown that there is a overload of cystine, lysosomal cystine in the both Leydig cells, like in the picture, but also in Sertoli cells. So maybe we can now in the future go further to analyze this situation. Finally, some cryo storage of semen could be an option for around 20% of these young males, but it would need some surgical sperm retrieval. And it had been shown by Konrad Weiss 4 years ago, a successive conception in a male with assisted reproductive technology. So I think it's an important topic to discuss with the males for the future. What about the pregnancy? Because my patients came to me after the renal transplantation telling me, okay, I just get married now, I want to have a child. For the pregnancy, regarding cystinosis, the first successful pregnancy was reported a long time ago. It was very interesting to see that here in the placenta, in the maternal portion of the placenta, there were some cystine crystals. But finally, this pregnancy was completely successful. Of course, like in all patients with a renal disease or in transplant patients, this kind of pregnancy should be planned. It is very important to have a multidisciplinary follow-up with a renal obstetric clinic with some expertise in complex pregnancies. We suggest to stop cysteamine at the time of a diagnosis of pregnancy because it has been shown that it could be teratogen. And if we look at the pregnancy in Europe, we observe increased risk of preeclampsia, also hypertension, and some cases of diabetes. But this risk probably depends mainly on renal function. And finally, some patients required some cesarean section because of cephalopelvic disproportion. So this is an overview of the cystinosis, in particular in adults. And so I think now the spectrum of the disease has extended from very renal disease to now a multisystem adult disease. And this is really a challenge for the adult nephrologists to have this multisystem clinic to follow the patients and detect the complication of the disease. The other challenge is the risk of non-adherence in these patients. And then we have to work on that with the patients. And there are also many psychosocial issues that have to be addressed. So thank you for your attention.
Okay, Aude, thank you very much for this very comprehensive review of cystinosis from the adult view. I'm very pleased to see that there are at least a couple of questions in the question box, which I asked for, of course. I'm trying to see whether I can group them a little bit. There are a couple of questions about diagnosis, I think. And one of the first questions coming in were, how commonly do patients report photophobia because of the cystinosis?
Yes, this is a symptoms. The diagnosis should be performed in very early childhood, so maybe it's difficult to in a very young child to have the report of photophobia. But of course, this is one of the main symptoms of the patients. And then when the patient is older, of course, you may ask the patient about photophobia, and this is an important point for the follow-up for the ophthalmological follow-up. But for the diagnosis, we hope that it should be done before. But,
yeah. And there's also somebody asking whether patients need corneal transplantation in the end.
Yeah, some patients may need corneal transplantation. Of course, I didn't get in the details for the ophthalmological part, finally all the part of the eyes may be they may have some crystals, and some patients may need some corneal transplantation. But I think it's not so easy, and now it's less frequent than in the past. The systemic treatment with histamine is not going to the cornea. That's why the patient needs the topical treatment. But the systemic treatment may also be important for the retinal part of the eye. But then I think it's very important to have an ophthalmologist which know more or less the disease, to have the specific follow-up and the specific treatment.
And also in the context of diagnosis, the question that is in the question box is there an indication for a kidney biopsy? And maybe the question should be, is there any indication for a kidney biopsy, or are kidney biopsies only taken in patients where the diagnosis is not immediately clear?
Yes, usually today the kidney biopsy is not necessary. With the Fanconi syndrome, you will have with the cysteine dosage, then you will have the diagnosis. So the kidney biopsy is not required. The kidney biopsy would show you some crystals, but once again, it's not so easy to have a look at the crystals. You have to not to solve the crystals when you perform the biopsy, so you have to be aware of the diagnosis before the kidney biopsy, just to be sure to see the crystals. But we don't perform any biopsy unless there is, of course, other problems, and then it's difficult to know exactly for which reason the patient has a renal failure. But usually we don't perform any kidney biopsy. The one I showed you, it's old in the it's historical renal biopsies. Mm-hmm. And just on renal biopsy, if you perform some renal biopsy on transplant patients, in some patients you may observe also some crystals, but it's not, of course, because of the disease not recurring on the kidney transplant, of course, but it's just because the host cells have some crystals and will go in the transplant. But it's sometimes nice to see these crystals if you perform some protocol biopsy in kidney patients.
Mm-hmm. Another question in the context of I think diagnosis, but also treatment. You look at leukocyte cysteine content in the diagnosis as well as in the follow-up, right? Does the cysteine storage in the leukocytes actually also impair leukocyte function? So is there an immune phenotype?
Yes, no, there is no immune phenotype. So there is no decreased immunity. I understand the questions, but finally the crystals are there, but there is not an increased risk of infection, or no, finally no.
Okay. But do you know whether that was studied, or because sometimes there's a blind spot?
Yes.
So this is actually a very clever question.
This is a very interesting question. It's for the immunity. We know that the macrophage have a role. So the macrophage have a role in cystinosis. And now the group of Elena Veshchenko is working on the macrophage and trying to have a look to find some other biomarkers. And it's more the biomarkers of macrophage that are involved. But yeah, I don't have any data specific on the immune system. But we had a look in our transplant patients, but it's only 30 patients, but it's already for stenosis quite good. And we didn't find any increased rate of infection, and anything, not more, not less rejection, neither. So, but maybe the function of the leukocyte should be looked by a specialist.
And the other question on the leukocyte cystine content is, how often should you check that?
So I think from the adult nephrologist point of view, because when you perform the diagnosis, you have to first adapt the dose, find the right dose. So in the beginning of the disease, probably you should have some numerous dosage. And for adult patients, I would perform it 2 to 3 times a year. Is it really useful? It's a good question, because finally, when you have the maximum dose, you will not increase it a lot. But I think from a psychological point of view, it's very important, because well, you see if the patient don't take the treatment, but of course he can take the treatment just the day before, and then the dosage will be good. But I think it's also important to discuss the treatment, discuss the efficiency of the disease, and that's why I would perform it twice a year. And of course, if you are in a country where you can switch from one form to the other, then in the patient who are switched, I performed some more dosage every 3 months to find the right dose of the new formulation compared to the old formulation.
And can you actually check with the leukocyte cystine content whether somebody is compliant? So I mean, how fast does it go down when you just, let's say, take the pills 2 days before checking the leukocyte content?
It's very quick. Okay. It's not a. That's why Elena Nevchenko is working on other biomarkers with a longer half-life. Because if the patients just take the treatment the day before, you will not see that he hasn't taken the treatment some weeks before. So it's not a good marker for that. We can also dose cysteamine, so you can see if the patient just took the dose before coming to your clinic, but it's not a very good marker. So it's very important to try to find some other markers, like for diabetes. Or...
Yeah. Another question in the question box is: are there any patients who are diagnosed for the first time in adult age? And I guess that is important because, I mean, probably the classical phenotype cannot be missed in infancy, but are there also, let's say, mild phenotypes that can, that present later on in life?
Yes, we spoke today about the classical infantile phenotype, which represent 95% of the patients, but the 5 other % of the patients are either adolescents or adult form. There is an adolescence form, so the patients have a less severe phenotype, and also an adult form. In the adult form, it was told in the past that it was only an ophthalmological form, but some time ago we had a look at all the patients who had an adult or an adolescent form in our clinic, and we found that finally some of these adult form, or I had some proteinuria and some mild renal phenotype. So of course it's very difficult to make the diagnosis in this case. I would say in this case, of course, the kidney biopsy could help, but you have to tell the pathologist that you are looking for crystals, and then in some patients you may find some FSGS, so it's not very specific. So in these FSGS patients, most of them have not a Fanconi syndrome or very mild Fanconi syndrome. But so you can ask for the ophthalmologic exam, which is sometimes useful in nephrology when you don't understand the diagnosis of your patients, and of course go for a cystine dosage. And in the other hand, in the patient with a proximal tubulopathy that you don't understand, it's important to perform some cystine dosage. So
nowadays, a little bit depending on where you live, you can do very comprehensive genetic screens, right? Are you aware of, let's say, cohorts of people with unexplained kidney disease, and then coming up with a cystinosis diagnosis there?
I'm not aware of that. I'm not aware of patients followed in our institution with FSGS reaching a stage renal disease around 20 years of age. And then sometimes after, his brother had also kidney disease, and the diagnosis of cystinosis was performed in the brother. And we performed some genetic analysis in our patients, and he had cystinosis with an adolescent form. So if it was a genetic, familial genetic testing, but in this whole genome, I am not aware of diagnosis of cystinosis.
Okay. And somebody is also asking what is actually known about the heterozygotes. Do they also have a mild phenotype?
No, they don't have some mild phenotypes. They have a cystine level increased, maybe around 1. That's why we try to have our patients a level below 1 to be like the heterozygotes. But they don't have any phenotypes as far as it has been very deeply looked for, and that they can give their kidney for renal transplantation without any risk.
So family transplantation is possible.
Yes, the parents can give the kidney to the children. It has been done for many years, and we don't have some warning about kidney function deterioration in the parents.
Okay. There were also some questions about treatment. Cysteamine treatment is, of course, important. I know that the pediatricians use indomethacin, and that also ACE inhibitors and angiotensin receptor blockers are sometimes used. What is your take on that?
So indomethacin is used in many countries for the Fanconi syndrome and the polyuria. And the ICA inhibitor too. This is two treatments that can be prescribed to cystinosis patients. In the recently published cohort of European patients by Francesco Hema, it tried to look if this treatment had a positive impact on renal function evolution, but finally it failed to demonstrate that the patient that had been treated with indomethacin or the patient who had been treated by a CA inhibitor had a better renal function in the long term. So we don't know yet if it has a very positive impact in the long term, but for the very important polyuria, indomethacin is used in many countries, including France, Italy, Belgium, and for the time being, it's still used.
And I was actually wondering, because you showed that the transplantation results actually seem to be better in cystinosis patients than in other patients. But I did not completely get what the idea behind that was, because I guess they have a lot of other morbidities because of the cystinosis. So is there, let's say, some complication of cystinosis that is actually protecting them after transplantation, or why is that?
No, it's just an observation. The first thing, of course, it's these patients have no the disease doesn't recur on the transplant, and then we try to have a look if the patient had less rejection or anything regarding renal transplantation. But we failed to find this. It's quite strange because now we know that the mTOR pathway is involved in cystinosis, and some patients may have some treatment with mTOR inhibitor, so maybe we could find some explanation around that, but no, for the time being, we don't have any explanation.
Okay. I have a comment here from Elena Levchenko, congratulating you on an excellent lecture. But she also asked whether you see more cardiovascular complications in cystinosis patients compared to other transplant patients.
No, it has been described, but we don't have a warning about cardiovascular complications. We don't have more vascular complications than in other patients with the same age, with the same past of renal failure. And I would say, as an adult nephrologist, we have less cardiovascular complications than in the older patients that we follow in adult units. So I don't think it's a very, important point. I know that the question has been raised.
But is that an age bias, do you think, that they seem to do better cardiovascularly?
For what?
But because they are probably on the mean younger than, let's say, the average transplant patient.
Yes, of course they are younger, but if we compare, I've not a study very well designed to compare this young patient with other young patients with other disease, but we didn't observe. I think there's more cardiovascular complication in cystinosis patient compared with other patients with other pediatric disease reaching adulthood. And in our patients, we don't observe that. We observed in the brain MRI some white matter anomalies, which was associated from the neuroradiologist point of view with vascular disease. But we observed the same complications. We had a control group, and the patient with other renal disease had the same aspect of. So they have some vascular problem probably, but not more than the other patients with renal failure.
And now maybe turning a little bit to the future, are there any new treatment possibilities coming up? Gene therapy, is that a possibility?
Yes, of course, that's a very important point for the future. Stem cell therapy has been developed by Stephanie Cherqui in the United States, and she has already treated some first patients with this stem therapy with very good results. So for the future, it will be a very important option.
Okay. Okay, I'm looking in the question box whether I missed, probably I missed one, for which I apologize immediately already. Let me see whether there are any new ones coming in. Well, I think the best one to close up with is the following one, which might be very important for cystinosis patients, but maybe also for non-cystinosis patients. How do you overcome the bad odor from the mouth?
That is difficult.
Yeah.
The bad odor, yeah? That is the question.
Yeah.
Yeah, the patients have different solution, some chlorophyll tablets or some different things like this. I would say that with the treatment, with low release treatment that can be taken only twice a day, the patient can choose when he takes the treatment. And so he knows that just after having taken the treatment, that the smell will be there, but then it decreases. So he can choose the time. And so this is an option. For some of my patients tell me, okay, I take it at that time, I know that I am home, and then, so they try to deal with that. But yeah, there is not a very good solution.
Okay. Okay, well, thank you very much. I guess also in the interest of time, I would like to close the discussion at this moment. Thank you again for the very good presentation and a very nice discussion. I would also like to thank everybody who attended and asked questions. It is also very nice to have these questions in the question box because that livens up the discussion clearly. we are not allowed to end this this webinar without announcing the next webinars. This week we are in luck, because in 2 days already there is an IPNA webinar by Francesco Emma on the approach to tubular disorders, and in particular salt-losing nephropathies. At the 5th of October, so in 2 weeks' time, there is another ERKNet educational webinar at this time as well by Martin Conrad about Bartter and Gitelman syndromes. On the 14th of October, there's another IPNA clinical practice webinar by Detlef Bockenhauer on distal renal tubular acidosis. So everybody who is very into tubulopathies, this is going to be an exciting month. Well, thank you all for attending. Aude, again, thanks very much for the interesting talk. And I hope to see you all again in 2 days or otherwise in 2 weeks. Bye-bye.
Bye-bye.